Hi, I'm Dr. Tracy Glauser, Director of the Comprehensive Epilepsy Center at Cincinnati Children's Hospital Medical Center in Cincinnati, Ohio. Today I'll be discussing the challenges associated with the identification, diagnosis, and treatment options for a syndrome called Lennox-Gastaut syndrome.
The following audio is part of a certified educational activity titled Optimized Management of Lennox-Gastaut Syndrome, A Patient's Journey from Initial Recognition to Treatment. Access the entire activity and complete the post-test at www.peerview.com/YNV. Downloadable slides and practice aids are also available.
Now, this is a devastating form of pediatric epilepsy that often starts in childhood. It's classically composed of multiple seizure types, abnormal EEG findings that are characteristic, and specific intellectual and behavioral disturbances. It's actually more common than you think. It typically starts between 1 and 7 years of age, is more common in boys than girls, and is seen in about 4 to 10% of all childhood epilepsy. Unfortunately, and this is one of the reasons we're talking about it today, its prognosis is poor, and less than 10% of people achieve seizure freedom as adults. But those are the global statistics. It's best to understand this syndrome from the point of view of a patient and her mother. So I'd like to share a story with you about a patient called Madison. Now, Madison was a perfectly beautiful, healthy young girl who during her 3rd birthday party experienced her first tonic-clonic seizure. The seizure lasted 4 to 5 minutes and involved both arms and legs associated with unresponsiveness, whole body jerking, and urinary incontinence. Her mother took her immediately to the emergency room, and she was evaluated there and admitted overnight for observation and discharged the next morning with follow-up with her pediatrician. Before she got to her pediatrician's office, though, in the next few days, her mother started to notice that Madison began having what she called head drops. And when you asked Madison's mom later on what these were, she stated that Madison would all of a sudden drop her head and her arms would extend very rapidly. And these first started just a couple of times in the first day, but then following the hospitalization, they started to occur more and more frequently, a few times a day, several times an hour. And they became so frequent that they appeared to also be affecting Madison's ability to do her usual activities. She had trouble asking for drinks or snacks or toys. She became frustrated. Behavior started to worsen. And worst in her mom's eyes, she started to not respond to her mom's requests in the same way that she used to. Her mom knew something was wrong and took her to the pediatrician's office for more urgent evaluation. She went to see her pediatrician, and her pediatrician reviewed her history, looking for any particular reasons why this otherwise beautiful, healthy little girl would suddenly have a catastrophic onset of these terrible seizures or these terrible events, because at that point the pediatrician thought they were seizures but wasn't 100% sure. He reviewed the history of the child. She was born at 39 weeks gestation. She had a normal birth weight, length, head circumference. Her APGARs were excellent. He went again through the developmental milestones, and there was no evidence of any developmental delay. And he searched for any history that the parents might have seen these events early in life, and the parents completely denied seeing them. He even quizzed the grandmother, because grandmothers are really good at recognizing things that the parents may not recognize, and the grandmother denied any problems with development. During his examination of her, he looked for skin lesions to give a hint. Was there any underlying genetic disorder? Because we know that the brain and the skin form at the same time, and skin lesions can sometimes give an indication of is there an underlying problem. He made a referral to the local pediatric neurologist, but along the way, he set her up for a routine EEG and a brain MRI. Now, the good news he was able to tell the family was the brain MRI was normal, but the routine EEG was terribly abnormal. And the pediatrician felt a little uncomfortable, not really knowing what this generalized spike wave discharges meant, but knew that these events had to be bad for the patient and a bad need or an important need, urgent need to go see the neurologist. So he decided to start the patient on valproic acid, because for him, a 3-year-old child with these onset of these spells that he thought was seizures, he'd had a lot of experience with valproic acid, and he thought that that was a reasonable starting point. Now, with the valproic acid, between the time of the starting of the valproic acid and the time of the neurology visit, Madison's mother noticed that things were better. The events were fewer in frequency, and when they did occur, they didn't cluster as much as they used to. So the pediatrician was happy, but not yet satisfied. So it was important for the pediatrician to really have the patient see the neurologist. So Madison showed up in the pediatric neurologist's office, where one look at the EEG recognized a very specific pattern, one that we are trained to look for and that's important to recognize. And that pattern showed generalized bursts of what we call slow spike and wave. So if you look at an EEG and between the vertical lines is roughly a second, or is a second, we see spikes that occur in all the channels. And these spikes are occurring at a frequency of about 1.5 to 2 spikes every second. And that's what we call a slow spike wave pattern. And in addition to these spikes that occurred over the entire EEG, there were some spikes of time in the left occipital region, and the background rhythms were a little slow. So the pediatric neurologist recognized right away that this was the classic pattern that we call a slow spike wave pattern. But the pediatric neurologist went one step further. She ordered an overnight video EEG, and she did it for 2 reasons. The first reason was, and this was the correct thing to do, is to see what the patterns looked like as Madison went to sleep at night. And the most important thing that shocked the families was that during the sleep part of the EEG, Madison had these bursts of what we call the run of rapid spikes, very fast pattern all together that was sometimes accompanied by stiffening or extension of both extremities in what was a tonic seizure. That was important for the pediatric neurologist to feel comfortable that yes, this was the classic pattern that you might see with Lennox-Gastaut syndrome. But the video EEG served another purpose. Madison was still having these events. And as these events occurred, the parent was able to say, that event I'm worried about, that event I'm worried about, and that event I'm worried about. And that allowed the pediatric neurologist to go into the family and say, you know what, every time you pointed at an event, that was a seizure. And so I want you to be counting or be aware of those events so that we can know how to evaluate the efficacy of our treatment. So we often will use those video EEGs not only for diagnostic purposes, but also to help the parents know what is a seizure and what is not. So at that point, the pediatric neurologist was faced with a very important decision. In that sense was this Lennox-Gastaut syndrome, or was it one of those other rarer syndromes that could mimic it? Because that has very important impact on treatment and prognosis. So the first step was for the pediatric neurologist to sit down and discuss with the family what is the classic triad of what we call Lennox-Gastaut syndrome. They learn names like tonic seizures with the stiffening. They learn names like the atypical absences, which are the brief staring spells with unresponsiveness associated with the change in the EEG pattern. They learned about what the pediatric neurologist called drop attacks. And these drop attacks were where there was a sudden head drop or arms drop. And the pediatric neurologist explained to Madison's mom that sometimes we don't know whether it's a tonic seizure or an atonic seizure, so we just call it a drop attack to sort of lump them together because Madison is having a drop in her body at that time. If we look at these multiple seizure types, there can be other seizure types that are noted, and that's the value of the video EEG to help capture them. But the key ones are the tonic seizures, the drop attacks, and then the atypical absences that we talked about with the family. And that gets coupled with the special EEG pattern. The special EEG pattern is important to recognize because there are things that can mimic it. That slow spike wave that Madison's pediatric neurologist picked up in combination with the video EEG picking up those run of rapid spikes, that paroxysmal fast rhythms that happen during sleep. And last, but certainly not least, in fact, most important for Madison's mom was that her beautiful little daughter was having intellectual slowing and regression. She was having behavior problems. Whatever had grabbed her at age 3 was really taking her daughter and turning her into something else. And she wanted to know, was this Lennox-Gastaut syndrome or was this something else? What do we do about it? How can she get her beautiful daughter back? But most importantly, the child neurologist really focused and helped Madison's mom understand that we're looking for a syndrome. We're looking for signs and symptoms that march together. And that allowed her to say, well, you know what? We can compare this to other syndromes, because there's about 30 syndromes in pediatric epilepsy. We can look at other syndromes and separate them out from what Lennox-Gastaut is. Madison's mom had done a lot of reading. Madison's mom knew that there was something called Doose syndrome, or myoclonic astatic epilepsy. Myoclonic with the jerks, astatic with the drops. And Madison's mom's like, well, why doesn't my child have that? That actually has a better prognosis. The child neurologist was able to say, there's some aspects that there is overlap, but there's clear separation. That in myoclonic astatic epilepsy, there's rarely impact on intellectual function, and it's really the myoclonic seizures that predominate. And in Lennox-Gastaut syndrome, which is what we think your daughter has, there's intellectual impairment and there's a variety of seizure types. Madison's mom listened carefully and said, you know what, you're right, it doesn't fit that. So then Madison's mom said, well, what about Dravet syndrome? That's another severe infantile myoclonic epilepsy. I've read about that. We can do things about that. And again, Madison's mom had done her homework properly, and the child neurologist was able to say, you know what, there are some overlaps, but Dravet syndrome presents at a much younger age group, less than 1 year of age. And yes, intellect is often impaired, and there can be these multiple seizure types, but it doesn't have this classic EEG pattern that Lennox-Gastaut syndrome has. So I do not believe your child has Dravet syndrome, but you know what? Let's do a genetic test, and let's look for sure whether the sodium channel malformation is there, or the sodium channel variant is there. They did the genetic testing. It turned out it wasn't there. So Madison's mom said, all right, I understand that too. So Madison's mom also asked whether Madison might have West syndrome. Well, this gave the opportunity to talk that West syndrome is typically at an onset less than 1 year of age and has an EEG pattern which is called hypsarrhythmia. Madison's mom said her first year of life had been perfectly fine and she didn't have any seizures, any events, anything worrisome. And so it was unlikely that Madison had West syndrome leading into Lennox-Gastaut syndrome because of this lack of seizures during the first year of life. Madison is a little over 3.5 years old. She has these multiple seizure types. She has the slow spike wave pattern. Of the different seizure types or the syndromes that we could identify, Lennox-Gastaut syndrome fits it the best. Because of her multiple seizure types, her slow spike wave pattern and that classic fast run of rapid spikes during sleep, her developmental regression, and the fact that she didn't really fit the patterns of the other seizures. So Madison's mom was okay. She wasn't happy, but she was okay about that, and she felt empowered to move forward knowing from the video EEG how to count her daughter's seizures and how to really play an active role in helping to try and help her daughter get better. But there were some key points that she still wanted to talk about before she asked about medicine. She wanted to know, what's the future hold for her daughter? She'd read enough. She knew that this was not a good thing for her daughter to have. She wanted to know what the prognosis was. At which point it opened the opportunity to have a discussion about what are the features of a child presenting with Lennox-Gastaut syndrome that are associated with having a long-term poor prognosis. And by doing that, Madison's mom allowed her and the pediatric neurologist a chance to talk about these poor prognostic features. Having pre-existing West syndrome, or that underlying infantile spasms, is a poor prognostic sign. Early age of onset, in age 2 years or less, is a poor prognostic sign. Having an underlying cause or abnormal neuroimaging with a brain malformation or an old stroke. Having bouts of continuous seizures like status epilepticus, or having a grossly abnormal EEG in addition to the slow spike and wave with lots of focal or motifocal spikes superimposed, are all poor prognoses. When Madison's mom heard these, she went down the list and she said, well, my child doesn't have pre-existing West syndrome. She's not at early age of onset. She didn't have symptomatic cause. She didn't have abnormal imaging. She's not had status. There's still hope. And there's still a chance that my child could come out of this on the other end with some semblance of a reasonable life. But is there anything worse that I should know about that we haven't really talked about? And that opened the opportunity to talk about what is the biggest fear of any parent of a child with seizures is, could my child die from this? Could my child have sudden, unexplained death from these seizures? It opened the opportunity to have that discussion with Madison's pediatric neurologist who knew right off the bat that frequent tonic-clonic seizures, that early age of onset, a long length of having epilepsy, having intellectual delay or disability, and having uncontrolled seizures were all risk factors for having sudden unexplained death in epilepsy. And Madison's mom felt a little reassured that early in this course she didn't have many of these factors, but it needed to be said, and it was one of the hardest things to talk about at the meeting, is that early death, sooner than any parent would ever want, does occur in up to about 15% of children and young adults with Lennox-Gastaut syndrome. So Madison's mom took a deep breath, okay? Very strong mom. She understood that her daughter had developed a devastating epilepsy. She understood that the doctors had done all the right tests, the MRI, the EEG, the detailed neurologic exam, the detailed history, had evaluated, was this epilepsy? Yes. Was it a syndrome? Yes. Are there other syndromes it could be? Not really. Doesn't fit. And that she really had Lennox-Gastaut syndrome. Mom was upset, but she felt empowered. She knew she could help track the seizures and play an active role. And she asked, all right, what about this medicine now? I'm ready to hear about medicines. What medicines are available? And that opened the door for another discussion. There are a number of medicines that are available to treat epilepsy, up to almost 20 different medicines that can treat different types of seizures. But the good news for Madison's mom in all of this was there are some medicines that have shown to be very specifically effective for the type of seizures that Madison was having. Some of them have very strong evidence to the point where the FDA has approved them for the treatment of seizures associated with Lennox-Gastaut syndrome, and others are more used because they're commonly used without any strong evidence. Valproate is one of them. However, we needed at that point to have a discussion about the 5 medications that are FDA approved for seizures associated with Lennox-Gastaut syndrome. They include, chronologically, Felbamate, topiramate, lamotrigine, rufinamide, and clobazam. It's important to realize that there's not going to be one drug that if we only find that drug, my child will be seizure-free forever. When you reach Lennox-Gastaut syndrome and have those seizure types, we need to realize that we're going to be dealing with seizures that are difficult to control. We're going to need probably 2 medicines. Sometimes we go to 3 medicines, but a key principle is let's try and keep the medication regimen as simple as possible. Another key point is we'd like to identify for any one particular child what is their foundation drug. Because if you've got 2 drugs on board, you can declare one of them a foundation drug and then cycle the other one in, cycle the other one out. As you add a drug, take away that non-foundation drug. So typically we talk about what's the foundation drug, what's the best drug for this child, and then what's the additional drugs on it. When we look at what drug to pick, we're going to focus on the most disabling seizure types. For some kids with Lennox-Gastaut syndrome, those drop attacks can be devastating. You can imagine sitting at the breakfast room table and all of a sudden you drop to the ground and your face smashes into the table. Then we want to try and match the drug with the patient. We realize there's not going to be a drug that's going to be the perfect drug forever and ever. So we realize we have to go over the list of drugs and talk about what might be a good match for that particular patient. And lastly, we want to warn families that sometimes the medicines can actually make seizures worse, that some of the seizures may be aggravated, so that's why we want to empower them to be partners in this and to help count the seizures. So although Madison was started on valproic acid, there are actually 5 medications that have FDA approval for the treatment of seizures associated with Lennox-Gastaut syndrome. For total seizures, lamotrigine, felbamate, rufinamide, and clobazam had better reduction in total seizure frequency as a median value for the treatment arm compared to the placebo arm. Now, when I said median, Madison's mom looked at me like, well, what does that mean? And I explained that in some studies, median reduction in seizure frequency is used, and in some studies, average reduction in seizure frequency. Median means half the patients did better, half the patients did worse. For example, with lamotrigine, slightly over 30% reduction in seizure frequency was the median value. Half the patients had a higher reduction in total seizure frequency, half the patients had lower. That was much better than the placebo arm, which was about 15%. This was true for lamotrigine, felbamate, rufinamide, and clobazam, but actually, topiramate, there was no significant difference in the total seizure frequency between the treatment arm and the placebo arm. And when we look at the drop attacks, whether we look at it in terms of the median reduction or the 50% reduction, all 5 of these did better as active treatment compared to the placebo group who got placebo as add-on therapy. Now again, a little statement, because some parents will come in and really ask questions about, I understand median reduction, half the group does better, half the group does worse. What's this 50% reduction? And the 50% reduction is felt to be a measure that the drug is actually working to some extent. So, and I warn parents about this, a 50% reduction is just what it says it is. We all want no seizures, no side effects, and the best quality of life. I didn't say 50% reduction we want 100% reduction. So this gives parents a sense of, okay, how many had a 50% reduction? How many cut their seizures in half? Usually 30 to 40% in these trials compared to placebo. One of the things that parents are extremely worried about is the toxicity of these medicines. And it's important to, when you've counseled the families, that the efficacy is not permanent, the efficacy is not guaranteed, the efficacy may be there for one drug but not there for another. Even though as a group it works well, it's important to also talk about the side effects. Not to scare the families, but to indicate that a wide variety of different side effects can occur with each and every one of these medicines. They will often ask you, I see the list of medicines. It's overwhelming. What do I really need to know? Well, let's pick lamotrigine. So one of the key things that we always talk to families about for lamotrigine is the risk of having a rash. Now, when we first started using lamotrigine, or testing lamotrigine and then using lamotrigine, we came to appreciate that there's certain things we had control over that could increase the risk of a very severe rash. And when I say severe rash, I mean Stevens-Johnson, toxic epidermal necrolysis, and even death. Those risk factors, which were preventable, include concomitant treatment with valproic acid, or a rapid lamotrigine titration, or starting at a very high lamotrigine dose. We also recognize that the younger age group was at a higher risk. These are preventable things. You can avoid using lamotrigine in a younger group, or if you have to use it, avoid using it with valproic acid, or do it at a very slow titration, or start at a very low dose. When it comes to topiramate, topiramate can have many cognitive type of side effects that aggravate some of the underlying problems we see in Lennox-Gastaut, and it can cause weight loss, so the kids sometimes will have decreased appetite and stop eating. And for some kids who have underlying medical problems, that can also worsen things. Rufinamide is slightly better tolerated in terms of not having some major serious idiosyncratic reactions, but you can still have side effects like somnolence, vomiting, and diarrhea. And our newest medication on our list of options for Lennox-Gastaut syndrome, clobazam, you can see somnolence and lethargy and tiredness with it. Now, the one that I didn't talk about is the one that most people have most questions about. We talked about lamotrigine and topiramate and rufinamide and clobazam, but felbamate is the one that has probably the greatest risk of side effects that are serious and that people worry about. And as such, we typically will position felbamate pretty much last on our list of options. It's an effective medication. Its efficacy is just as good as the other medications, but there is a risk of both aplastic anemia and hepatotoxicity. Now, if you've had problems with liver issues in the past if you've had problems with aplastic anemia or any blood problems in the past, Felbamate would not be one to go on. But each one of these issues, aplastic anemia and hepatotoxicity, should be discussed with families before you start with Felbamate. And there are non-medicines we could talk about also. Madison's mom wanted to hear more. She had heard enough about medicines. It had been 15 to 20 minutes of discussion of how everything could go wrong. She wanted to know what else is there. So a discussion was held about the ketogenic diet. And the ketogenic diet is a very effective treatment, although for some families, hard to institute. In general, it can be effective and wonderful for some families. And there's been some nice studies that talk about how well the ketogenic diet can work for Lennox-Gastaut syndrome. And it's important potentially to do that in a standardized system, and there's a number of keto centers around the country that many families would like to go to so that they get a ketogenic nurse and they get people who are used to the ketogenic diet. But the ketogenic diet should definitely be in the discussion. But there's also surgical options that can be helpful for patients who have Lennox-Gastaut syndrome. For example, vagus nerve stimulation, the implantation of stimulators under the skin and running up the stimulator cord to the vagus nerve can be very helpful to help reduce seizure frequency. It does not have any level 1 evidence for its effectiveness in Lennox-Gastaut syndrome, but there's a significant number of case reports out there. In the old days, before Felbamate came out, once the standard medications had failed, we often turned to a surgical procedure called corpus callosotomy, where we would do the split brain operation. Mom sort of recoiled when we talked about that, and she was not interested in hearing about acute disconnection syndrome or apraxia. She was like, I'll hear about vagus nerve stimulator, but let's put corpus callosotomy off for right now. But she came armed with a very specific question. She said, I've heard a lot of things in the lay press about cannabidiols and the extract from the marijuana plant called Epidiolex. And great question. It opened the door for a discussion that there was an open label study that showed that it reduced total and dropped seizure frequency. But there are a couple of things. It showed an interaction between cannabidiol and clobazam, possibly giving synergy, but clearly there's this concern about drug-drug interaction that needed to be talked about. And then a recent study that Madison's mom was very interested to hear about a randomized double-blind placebo-controlled trial as add-on therapy that showed further promising results for efficacy, but it's not yet available and not yet FDA approved. So what happened next? She had been on valproic acid. Madison's mom said, you know what? I heard what you said about valproic acid and lamotrigine. Let's not move to that. Let's talk about the topiramate. I'm going to think of valproic acid as my kid's foundation drug. I know it's not got that level 1 evidence, but it really helped for her initially. And on the list, as she effectively looked down it, she said, what about rufinamide? To which her pediatric neurologist said, you know, rufinamide, clobazam, even Felbamate could be options. They all have roughly the same efficacy. They all have different side effects. And for your daughter, rufinamide's a very reasonable choice. So they spent the next few minutes talking about, well, how do you start it? What formulation does it come in? Have our goals changed? And it led to a very interesting discussion about our goals were always no seizures, no side effects. But by this time, Madison's mom understood that we had a very low chance of getting to no seizures. So the goal had changed to be as few seizures as possible, with as few side effects as possible, with the best quality of life for my beautiful daughter. And those are wonderful, wonderful goals. And that we noticed that as we went to rufinamide, that her seizures had meaningfully reduced in combination with the valproic acid. But as time went on, and as we kind of expected, and as Madison's mom continued to keep daily diaries, she started to see that it continued to sort of slope upwards. At which point, about 6 months later, she came into the office and said, I think it's time to switch. I don't think the rufinamide's working. I've been looking at my numbers. Here's my sheets. I made Excel spreadsheets and charts. Parents do that. And she said, let's think about what else I could go to. So you pull out the list again, and her pediatric neurologist said, we've got clobazam, we've got Felbamate, We still have the ketogenic diet. We have vagus nerve stimulator. Madison's mom said, let's go with clobazam. So in conclusion, Lennox-Gastaut syndrome is a devastating pediatric epilepsy syndrome occurring during childhood and characterized by multiple seizure types, including tonic seizures, drop attacks, and the generalized tonic-clonic seizures, an EEG pattern with slow spike and wave, and both developmental and behavioral regression. As Madison's mom learned through this experience, there are multiple FDA-approved options for those patients who have Lennox-Gastaut syndrome. Those include Felbamate, lamotrigine, topiramate, rufinamide, and clobazam. And last, but most important, when it comes to patients who have Lennox-Gastaut syndrome, it's critical to set expectations properly about how well we can do with our therapies and to help families reach, in partnership, the goal of the best quality of life, the fewest seizures, and the fewest side effects.
This activity has been jointly provided by Penn State College of Medicine and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at www.peerview.com/YNV. This activity is supported by an educational grant from Lundbeck, LLC.